Welcome. NSG 419 Study Section 4 Community Midwifery Care. Introduction. The role of the midwife is to promote the health and well-being of mothers and babies and to support sound parenting and stable families. It encompasses care from the pre-pregnancy through the puerperium. A midwife is a person with midwifery skills. She or he has successfully completed the prescribed course in midwifery in an education program and is able to give the necessary supervision, care, and advice to women during pregnancy, labor, and the postpartum period, to conduct deliveries alone, to provide life-saving obstetric care, and to care for the newborn and the infant. Learning outcomes. When you've studied this section, you should be able to highlight the roles of midwives, define home birth, and discuss the reasons and criteria for home delivery. Describe the midwife's responsibility before, during, and after home birth. Conduct referral. The role of midwives. Worldwide, midwives assume the primary care of women during the reproductive year, support healthy behaviors in women, and have the skill to prevent maternal and infant death and morbidity in many cases, detect abnormal conditions in mother and child, procures medical assistance if needed. Continuation of role of midwives. Execute emergency measures in the absence of medical help. Provide health counseling and education, not only for the woman, but also within the family and community. Antenatal education and preparation for parenthood. Gynecology, family planning, as well as infant and child care. Midwifery and maternal mortality. Assist in the prevention of maternal and child mortality and morbidity by providing nutritional education, family planning services, birth spacing, contraception, safe sex information to prevent STDs, HIV or AIDS, and cervical cancer. Role of the community midwife. During the antenatal period, confirmation of pregnancy and to discuss options of care. Ensure that pregnancy remain confidential. Take a full medical, obstetric, and social history. In the light of the client's history, make plan to suit the client's individual needs, either at home or at the clinic. A thorough examination of the woman from head to toe so that she can identify any problem and respond to her needs appropriately. The midwife must know how to refer the woman to appropriate person if she requires additional medical care. Supporting women and their partners in the transition to parenthood and providing optimal counsel for growth and development of babies. Postnatal care. A survey of maternity services across 137 NHS trusts showed that just 25% of women saw a midwife once or twice after going home. The results from more than 23,000 responses also suggest that since the last survey in 2010, more women wanted to see a midwife more often and fewer felt that they saw a midwife as much as they wanted. CQC 2013. The postnatal period means a period not less than 10 and not more than 6 weeks after the end of labor. As stated by the NICE Quality Standard 2013, the first 10 to 14 days after birth are crucial for the assessment of both physical and emotional changes. Aims of postnatal care: to promote recovery from birth and monitor the health, growth, and development of the baby, to encourage independence of the mother in the care of herself and the baby, and to support the family in their new roles in relation to the baby. Postnatal care: the provision of psychological support, identify satisfactory involution of the uterus and healing of the perineum, recovery of normal bladder and bowel function, normal blood oxygenation and circulation, and the absence of signs of infection. The latest quality standard NICE 2013 outlines the need to assess various aspects of mothers' physical and mental health postnatally. It recommends the use of an individualized care plan for each woman and stresses the need for women themselves to be aware of any signs that her own health or that of her baby may not be well. Checking the postpartum hemoglobin and the examination of the breast, uterus, and perineum and general well-being of the mother. 5 key issues that are based on the NICE 2013 quality standard. These include reviewing each woman's personalized care plan at each of the minimum or 3 postnatal contacts, providing breastfeeding information and support, and assessing women's emotional well-being. Home birth. Home birth. Home birth is the birth of a baby in the family home, which could be planned home birth or unplanned. Reasons for home birth: when mothers feel safer at home. Take 2 action. I've had a previous positive birth experience in hospital and now feel confident about birth at home. Dislike being in hospital. Are expecting their first baby and are worried about the effect of a hospital environment on their labor. Want to reduce the risk of infection. Continuation of reasons for home birth. Don't want to be separated from older children. Want to avoid overnight hospital stay without partner. Hope to use a birth pool and cannot be sure that this will be possible in hospital. Want privacy. Criteria for home birth. Women with normal pregnancies who are physically, socially, and mentally suitable. Contraindications for home birth: when there is any deviation from normal or when complications are anticipated, like previous difficult birth or postpartum bleeding, previous cesarean section, over 42-week gestation, hypertensive clients, 5th or subsequent babies, breech, multiple pregnancy, or any form of malpresentation. Unbiased information should be given to enable the woman take a decision. Points for discussion in preparation for home birth: the advantages of home birth and provision of information, the role of the midwife during a home birth including the conduct of labor and what the midwife will do in specific circumstances. Explain how to contact the midwife when in labor, how often and when the woman will be visited, how to contact the local home birth support group if one exists. The room: protection for pillows, mattress and carpet, e.g. polythene covers and old sheets, spare bed lining, reliable heating or an air conditioner and lighting including an angle poised lamp if possible, clear surfaces, bathroom or other washing facilities with soap and towels, equipment required for home delivery, maternity kits, pack to be delivered to the woman's home at 37 weeks, containing cotton wool balls, sanitary pads and absorbent pads, vaginal examination packs. Essential equipment in the midwife's delivery bag: Pinard stethoscope and sonicide, sphygmomanometer, urine testing equipment, Entonox equipment, oxygen in small cylinder, portable suction machine, intravenous giving set, plastic bags for clinical waste, sterile gloves, Amni hook, glycerin suppositories and phosphate enema, urethral catheters, cotton wool balls, delivery pack, suture pack, maternal drugs, baby equipment, baby drugs, blood bottles. Managing pain, self-help techniques. Different positions. At home, client is free to labor in whatever position she finds most comfortable. Movement: swaying, walking, dancing, circling hips, focusing on breathing, breathing out very slowly, panting. Midwife can administer Entonox and pethidine as appropriate. Pain management: vocalization, making sounds, e.g. singing, mooning, humming. Distraction: keeping busy, watching TV, listening to music. Warm water: a bath, shower or birth pool. Many women find a birth pool very effective. Intrapartum care: identify problems early and transfer to the next level of care. Prolonged or obstructed labor, use of pantograph. Life-saving skills for mother: delivery of placenta, management of maternal hemorrhage, oral rehydration. Labor complications: prolonged first or second stage, meconium, stained liquor, fetal heart rate abnormality, antepartum hemorrhage, shoulder dystocia, postpartum hemorrhage, retained placenta, birth asphyxia. Oral fluids given, infant care, cutting of umbilical cord, neonatal resuscitation, breastfeeding, postpartum care, family planning or child spacing, promotion of breastfeeding, exclusive breastfeeding, promotion of breastfeeding, POPPI, prevention of postpartum hemorrhage initiative, expand the use of active management of the third stage placenta delivery, make uterotonic drugs and devices available at low cost. Postpartum care: early identification of problems with mother, hemorrhage, infection, eclampsia, early identification of problems with infants, prematurity, difficult breathing, need resuscitation, infection. Referral system. In Nigeria, limited access to obstetric services is a major problem contributing to high maternal and infant mortality. It is therefore imperative that effective and efficient system on reproductive health be established to link all levels of health services. This module explains the basic knowledge and practice of two-way referral using the current model of healthcare system in Nigeria. It is expected that health workers utilize this model to strengthen the system. Definition of referral. Two-way referral is a process where a provider sends a patient to the next level of care for further management and gets a feedback from the referred health facility. Advantages of referral. increases patients' chances of receiving better care, increases patient satisfaction, decreases morbidity and mortality rates, instill confidence in the healthcare system, that is, both providers and clients are assured of access to quality care, allow cross-fertilization of ideas between healthcare providers, enhances transfer of knowledge between providers, facilitates continuum of care. Danger signs for referral. Danger signs are clinical signs and symptoms that require immediate attention in order to save the life of the patient. These are common danger signs: murder, headache, fainting, abdominal pain, bleeding from the vagina, swelling of the face, hand and legs, weakness, lethargy and breathlessness, foul-smelling vaginal discharge without delivery, fit and convulsions, loss of consciousness, fever and chills, decreased or absent fetal movement, draining of liquor, severe vomiting, labor lasting for more than 12 hours, newborn, difficulty in breathing, low birth weight, congenital abnormality, high temperature, twitching, yellowish discoloration of eyes, etc. Mother, monitoring vital signs, BP, pulse, respiration and temperature, monitoring of contraction and fetal heart, prevention of shock, maintaining IV line, reassuring the relations, monitor input and output. Newborn, provide warmth, continuous feeding, vital signs, respiration and temperature, reassurance to family, position baby accordingly, suctioning of baby, etc. Difficulties in going for referral. Sometimes even the family knows the baby or mother should go to the hospital, they don't go. It is important for the CHW to understand their reasons so they can help families overcome these obstacles. Midwives care for pregnant women who are seen as low risk. Women who have complicated pregnancies usually have full hospital care managed by midwives and obstetricians. Thus, there are various models of care for expectant mothers. Shared care. This is antenatal care shared between the hospital, obstetrician and midwife, and the community, our GP and midwife, with delivery in the hospital under the care of the hospital staff. After discharge, postnatal care is provided at home by community midwife and GP. The disadvantage of shared antenatal care is that care is fragmented and women see many different health professionals. It can also lead to interprofessional difficulties if there is no clear pattern of responsibility. An extension of shared care is the domino service, domiciliary midwife in and out, where as well providing antenatal care in the community with the GP. The community midwife also delivers the baby in hospital. If medical assistance is required, it's provided by hospital obstetric staff and the GP has no role in intrapartum care. In some cases, there are special informal style delivery rooms set away from the main delivery suites. In others, The community midwives work alongside of hospital staff. The midwife then arranges for the woman to be discharged home, usually within a few hours of birth. This style of care has proved popular with women but has usually only been available to a few. Community midwives, who frequently deliver babies in hospital, maintain their skills and close working relationship with the hospital staff, providing cover for midwives to undertake the range of duties in the community, as well as being on call for deliveries in hospital can be difficult. More recently, schemes have been developed to improve continuity of the care for women. Team midwifery consists of teams midwives who work together to provide care throughout pregnancy, labor and the puerperium to give continuous, coordinated women-centered care. The Know Your Midwife scheme showed how continuity could be improved while at the same time radically altering the midwife's working week. Deliveries and evaluation showed a greater satisfaction with care and reduction in the use of analgesia. Bennett and Brown, 1999. Obstetric-led care. For those women who are classified as being in high-risk groups, consultant-led model is the safest option and therefore must be provided in a modern maternity system to promote safety for both mother and child in high-risk groups. Study section summary. In this study section, you pointed out the roles of midwives, you examined home birth and discussed the reasons and criteria for home delivery. You also described the midwife's responsibility before, during, and after home birth. You capped the section by exploring referral. Now we've come to the end of study section 4. Thank you.